Bismillah ar-Rahman ar-Rahim. We come to the regional orthopedic problems, and we started by the upper limb. And the first region to be discussed is the shoulder and pectoral girdles. Introductions. Shoulder joint is composed of the multiple joints and synovial sheaths compartment that works together as a complex girdle to permit the free movement of the arm. It is the proper shoulder joint between the glenoid and the humeral, and also a part of what's called scapulothoracic joint, which is a muscular part of the joint to complete the range of the movement. We come to the sign and symptom of a disease in the shoulder. First of all, in any orthopedic problems, the pain from the neck or the shoulder joint, rotator cuff, or the trapping of referred pain. Now, sometimes the shoulder pain, it is starting or is origin from the shoulder itself, or referred or radiated from the side, like the referred from the pain, or radiated from the neck, or referred from the mediastinum disorder, including cardiac ischemia. Also, sometimes of the lung lesions like Pancoast tumor in the apex of the lung, and so on. And the type of the pain, whether aching pain or stabbing pain, and so on. Weakness is the second classic symptoms, and instability, stiffness, swelling, and loss of the functions. The most common sign in the shoulder problem are the swelling and sometimes deformities or wasting of the muscle and deformed posture of the shoulders. So that one can look and feel or move as the classic examination of any part in the orthopedic. Looking for the skin, shape of the shoulder, roundness of the shoulder, the posterior part, anteriorly, and so on. And also feeling the skin and bony prominent parts on the joint margin, and so on. And move active movement and passive movement, and see or measure the range of the movement and the full range of the movement, which are including abduction, adduction, flexion, extension, internal and external rotation, and the other movement was called circumduction, which is including all these movements together to form what's called circumduction, like those when the swimming, when a patient or somebody can move the upper limbs and around the in front of the body in all directions. Here we have a box including the painful shoulder conditions, either referred pain syndrome, which is for cervical spondylosis, mediastinal pathology, cardiac ischemia, and so on, or joint disorder like humeral arthritis, acromioclavicular arthritis, or bone lesion like infection and tumors, or rotator cuff disorder like tendinitis, rupture, frozen shoulders, or unstable like dislocation and subluxation, and nerve injury, the suprascapular nerves, and entrapment may be causing the shoulder pain. We come to the specific lesions which are commonly we are facing in our practice. First of all, rotator cuff disorder. The rotator cuff is made of the lateral portion of teres minor, infraspinatus, supraspinatus, and subscapularis. All these four muscles form a conjoint tendons which is inserted into the greater tuberosity of the humerus. And a contraction of individual muscle that makes up the rotator cuff exerts a rotational pull on the proximal end of the humerus. The main function of the conjoint structure is to draw the head of the humerus firmly into the glenoid socket and stabilize it so that the patient can move and can do an abduction and other range of movements when it is stabilized in the glenoid. Otherwise, it is difficult to do any movement without stabilization of the head of the humerus in the glenoid fossa by this conjoint tendons. But here the picture, you see it. This is the rotator cuff groups of muscles, and here the biceps passing through the joint capsule, and here the glenoid fossa, and here the tendons surrounding the shoulder, forming the conjoint tendon and was called supraspinatus, or was called rotator cuff. Here you see it clearly, the subscapularis and the supraspinatus, and here the infraspinatus, and this is teres minor. The common cause of pain around the shoulder, rotator cuff syndrome, supraspinatus impingement syndrome, and tendinitis, tears of the rotator cuff, acute calcific tendinitis, adhesive capsulitis was called frozen shoulder, and bicep tendinitis and or rupture of the biceps tendon. These are the main pathological conditions that causing pain around the shoulder and arise from structure near the joint itself. Impingement syndrome, supraspinatus tendinitis, and cuff disorders. The pathology: a painful disorder which is thought to arise from the repetitive compressive or wrapping of the tendons, mainly supraspinatus tendon, under the coracoacromial arch. As we know, the acromion is the prominent part of the scapula, and it is attached to the ligament that connect it to the coronary process, and this form a crescent arch underneath the supraspinatus muscle will passing through and through. This ligament, this is acromion, and this is the ligament coracoacromial ligament, and here a crescent structures, which is the bony tendinous part underneath the supraspinatus will be go on through and through, and here it might be wrapped underneath this crescent shape. Crescent structures might be wrapped, and repeated stress on it might lead to the lesion in it. Impingement, the impingement position, abduction, slight flexion, and turn rotations. The site of impingement is called critical area, where supraspinatus tendons may also occur in response to severe repetitive stress, where the supraspinatus muscle or tendons comes beneath this crescent structures or arch. Here you see it. This is the head of the humerus where it's abducted. This is the bursa, and here the tendons, supraspinatus tendons, where it is come beneath this bony part and maybe undergo a friction and repetitive stress on it. Factors which may predispose to repetitive impingement are including osteoarthritis or thickening of the acromioclavicular joint, swelling of the cuff or the subacromial bursa. So lesion here, either in the joint or in this bursa, such as in the gout and rheumatism, and variation of the acromial morphology. Acromion may be, in some patient, it is abnormal in its pathology, like spike of the bone may be go down and impingement on this structure, these structures. So the lesions either in the bone itself or in this joint or in the bursa. These factors may predispose to repetitive impingement, may be predisposed to this repetitive stress and trauma to this conjoint tendon, leading to the tendinitis and impingement. So that degenerative process might lead to the trauma. Trauma is vascular reaction causing swelling, and this swelling causing impingement. And impingement also lead to the cuff disruption and maybe end with osteoarthritis. This is a circle or vicious spiral of rotator cuff lesions. Each one lead to the other and end with osteoarthritis of the shoulder and acromioclavicular joints. Here the main pathology which occurs here, as you see, this is the rotator cuff, and this is subacromial bursa, and this is may undergo friction beneath the bone acromion and the greater tuberosity, and here leads to the friction and vascular lesion, and degenerative process occurs in the tendon. Clinical features of this condition: impingement, pain and or weakness over the front and lateral aspect of the shoulder during activities with the arm abducted and medially rotated. Abducted and medially rotated. Tenderness, a 3 pattern encountered: subacute tendinitis, the painful arc syndrome, due to the vascular congestion, microscopic hemorrhage, and edema. Chronic tendinitis, recurrent shoulder pain due to tendinitis and fibrosis, and cuff disruption, recurrent pain and weakness, and loss of the movement. This is the last stage when there is loss of movement due to tear of the rotator cuff. So it starts by subacute tendinitis in a form of hemorrhage or microscopic hemorrhage and edema, and this is by chronicity lead to the chronic shoulder pain and tenderness and fibrosis, and then this might be disrupted, leading to the loss of the movement. These are the clinical pictures of the impingement syndrome. Imaging: the X-ray normal in the early stage. Chronic tendinitis by caudal tilt view, maybe see the narrowing of the joint space, erosion, sclerosis, or cyst formation at the site of the cuff insertions, osteoarthritis of the acromioclavicular joint, and by ultrasonography and MRI, usually you can't diagnose the lesions. By MRI recently, we can't diagnose the lesion in the supraspinatus tendon, especially the rupture. Or by X-ray, we can see the calcification, acute calcifications, and by MRI, we see also the lesions, and by X-ray, usually you can see the osteoarthritis of acromioclavicular joint. Treatment: either conservative or operative. Conservative: avoiding the impingement positions, which is usually in abduction and interrotations, and physiotherapy, a short course of the non-steroid anti-inflammatory drugs, and if all these methods fail, the patient should be given 1 or 2 injections of the steroid with a local anesthetic. And the protective modification of the shoulder activity for at least 6 months usually needed. If these conservative measures fail, surgical treatment indications are if the symptoms do not subside after 3 months of conservative measures, and if they recur persistently after each period of treatment. And the indication is more pressing if there are signs of partial rotator cuff tears and full thickness in a younger patient. So that the indication of surgery, failure of conservative measures, or recurrent attacks after a period of treatment, or in a case of when we clinically or by MRI we diagnose partial rotator cuff in a young patient or full thickness in a young patient, especially in the young patient, because they need to regain their activities, they need surgical repair. The object is to decompress the rotator cuff and repair of rotator cuff tears if it is indicated. What's the indication of rotator cuff repair? Repair the tears and the chronic pain, weakness of the shoulder, and significant loss of the functions. And the younger and more active the patient, the greater the justification for surgery. So these are the main indication of surgery in rotator cuff tears. Acute calcific tendinitis. Acute shoulder pain may follow deposition of calcium hydroxyapatite crystals, usually in the critical zone of the supraspinatus tendons. Local ischemia leads to the fibrocartilaginous metaplasia and deposition of the crystal by the chondrocyte. What are the clinical features of acute calcific tendinitis? The age usually about 30 to 40 years, and aching agonizing attack of pain after a few days, pain subsides. During the acute stage, the arm is held immobile, and the joint is usually tender to permit palpation of the movement, like a sign of infections. The patient cannot move his shoulder, and you can't even palpate the site of the lesions. Here, you see the X-ray classification of the tuberosity, and here the measure of treatment. X-ray classification about the tuberosity usually, and treatment, non-operative treatment, conservative treatment is successful in about 90% of the cases, and the main methods are non-steroid anti-inflammatory drugs plus subacromial injection of the corticosteroid, physiotherapy, extracorporeal shockwave therapy, and needle aspiration and irrigation, sometimes with blood, which was called irrigation by normal saline and injection of the steroid also. And operative treatment surgery is indicated for a patient with severe disabling symptoms which have persisted for more than 6 months and they are resistant to the conservative treatment. And a subacromial decompression is also usually performed, and this has been shown to be successful in around 90% of the many outcome studies. So that the operative treatment is indicated in disabling symptoms and in a form of subacromial decompression. Subacromial decompression, that's all. Goes here, note here, just presentation of the calcified materials. Biceps tendon lesions. As you know, you have two heads of the biceps, the long and the short head of the biceps. And the long head of the biceps is the common site of the pathology of the shoulder pain, and clinical version is often difficult because it is go inside the joint and often associated with degenerative or rotator cuff conditions, and failure to treat the long head of biceps can be a cause of the continuing symptoms. Sometimes it is you can give analgesia and anti-inflammatory drugs, but no response because the inflammation of the long head of the biceps. Tendinitis. Clinical features usually occurs together with the rotator cuff impingement. Tenderness usually resists flexion with the elbow straight and forearm supinated, what's called speed test. Now, the forearm supinated and try to flex the elbow from the straight position by resistance. With resistance, this is called speed test. Initiate the pen and resist supination of the forearm with the elbow bent. This is Yegerson test. Of all of both these maneuvers initiating pain in the shoulder. Treatment: rest, local heat, and deep transfer frictions usually bring relief. If recovery is delayed, corticosteroid also injection with the local anesthetic. For refractory cases, a number of surgical solutions have been described, including arthroscopic decompression, biceps tenotomy, and biceps tenodesis. We suture the long head to the short head, and that's all. If we have rupture, clinical features usually accompany rotator cuff disruptions, and the patient is usually aged over 50 years old. While lifting, he or she feels something snaps in the shoulder, and the upper arm becomes painful and bruises. Ask the patient to flex the elbow, and the side belly of the biceps forms a prominent lump in the lower part of the arm, the crowning muscle. Treatment: isolation tears is the elderly need no treatment, leave it. And however, if the rupture is a part of rotator cuff lesions, and especially in the patient young and active, this may indicate for anterior acromioplasty and repair the lesion or tenodesis to the other tendons. You see rupture, long head of biceps, crowding of the muscle here. And here the lesions, and usually you excise part of the acromion here, was called acromioplasty. Acromioplasty. Underneath the acromion, rough, underneath which is rough, you need to be smooth and irrigated and smoothing of the surface and debride it by arthroscope or by open methods. What's called acromioplasty. Slab lesions. Here we have a compressive loading of the shoulder in a flexed abducted position, for example, in a forearm outside hand, can damage the superior labrum of the shoulder, anteriorly or posteriorly. This is called slab lesion. Superior labrum anterior posterior injury. Superior labrum anterior posterior lesions. Adhesive capsulitis, what's called frozen shoulder. This is one of the commonest orders, especially in the elderly, especially those with history of diabetes mellitus, and in a form of regressive pain or stiffness of the shoulder, which is usually resolved spontaneously after about 2 years. The histological features are reminiscent of the dupuytren disease in a form of fibrosis of the capsule, in a form of capsulitis. Active fibroblast proliferation in the rotator intervals, anterior capsule, and coracohumeral ligaments. Associated with diabetes, dupuytren disease, hyperlipidemia, cardiac disease, and hemiplegia, and it is usually a part of what's called hand-shoulder syndrome. It occasionally appears after recovery from the neurosurgery. For me, I put a 3-point or classic factors that initiate this problem. First of all, the age. It is commonly in the elderly patient. Second, diabetes mellitus, especially those badly controlled. And third one, trauma in the form of pulling or traction of the shoulder. So if we have 2 of these 3 factors, trauma with diabetes, trauma with elderly, diabetes with elderly might precipitate this condition, what's called frozen shoulder. In the clinical features, usually the age about 40 to 60 years, history of trauma and aching pain in the arm or shoulder. Stiffness, if entry stiffness persists for another 6 to 12 months. Usually it takes about 2 years. And slight wasting, tenderness is seldom marked, and cardinal feature is stillborn lack of the movement in all directions, especially internal rotation and abduction. The main movement most restricted are abduction and internal rotation. And the disease passes in 3 stages. First stage of painful condition, second stage pain and stiffness, and third stage painless stiffness. And each one might go from 6 to 8 months. Differential diagnosis of the frozen shoulder infections, post-traumatic stiffness, diffuse stiffness, reflexive body dystrophy, or what called hand-shoulder syndrome. And here you have this in a capsule. So usually we see the fibrosis in the capsule of the joint, narrowing of the joint space, and fibrosis and adhesion in the capsule. Treatment. Conservative treatment, analgesia plus anti-inflammatory and pendulum exercise like the pendulum by flexion, extensions, and medial adduction and abduction with rotatory movement, internal and external rotational like a pendulum movement, pendulum exercise, and manipulation under anesthesia with injection of the corticosteroid with local anesthetic. Injection large volume of about 5 to 200 ml of the sterile saline under pressure. These are procedures leading to the destruction of the adhesive capsule and stretching of it. And second one, operative treatment, arthroscopic capsular release. Good result of the pain relief and increased range of the movement can be expected in the majority over a short period of time in those with manipulation anesthesia or with arthroscopic debridement. Osteoarthritis of acromioclavicular joint, common in the middle age and old peoples. A predisposing factor is trauma in a form of the subluxation of the joint, and occupational stress, habitually carrying a weight on the shoulder or working with a pendulum with a pneumatic hammers and drills. Usually these persons or these laborers liable for acromioclavicular joint osteoarthritis. So it is commonly in the right side in those right hand dependent. Clinical features: shoulder pain, prominent lump at the outer end of the clavicle, and usually tender area. The X-ray shows characteristic features of osteoarthritis of acromioclavicular joint. Treatment: analgesia, steroid injection, excision of the lateral end of the clavicle, the last choice. Here you have osteoarthritis of acromioclavicular joint, and you see the prominent part of the joint become prominent by fibrosis. Here we come to the one of the important part in the pathology of the shoulder is the shoulder instability. The shoulder achieves it is uniquely wide range of movement at the cost of stability. As we have a joint, if we have a wide range of the movement, definitely that joint not so good stable. And pathogenic classification of the shoulder become unstable because one of the structural changes or unbalanced muscle recruitment, either structural problem or the muscles surrounding the shoulder are unbalanced, either by disease in the nerve or disease in the muscle itself or rupture in the muscle as well. So we have a three-polar type. First of all, traumatic structural instability. Second one, atraumatic or minimal traumatic with structural instability. And third one, atraumatic non-structural instability, which is muscular dyskinesia. So the instability by three polar types we can classify into three groups of instability. Here in type 1, the pathology, trauma, the articular surface damage, and the capsular problem in abutment lesions and laxity usual natural and muscle pattern normal, and a second type difference, and third type also some difference. Traumatic anterior instability, polar type 1, traumatic, non-structural. Commonly types is the common type of it because of trauma in the shoulder joint, and 95% constitute of instability of the shoulder joint. Usually follows an acute injury, which is acute shoulder dislocations. As we discussed in trauma in the first 10 lectures, anterior shoulder dislocation, one of the commonest type of shoulder dislocations. Classically, might end with Bankart lesion, which is disruption of the labrum in the anterior part, or with a health sac lesions where there is abrasion of the superior lateral part of the head of humerus. In other cases, the labral tears and bone defect may be absent, although the inferior glenohumeral ligament will be stretched. If the patient over the age of 50, dislocations is often associated with tears of the rotator cuff. Clinical features: young men or women who give history of shoulder coming out, recurrent dislocation, require treatment, develops in about 1/3 of the patients under the age of 30 and about 20% of the older patients.